Welcome to our Caribbean and African Targeted Health Improvement Program, CAHN Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CAHN is funded by the National Lottery Community Fund.
Hello and good morning. Welcome once again to another Saturday morning where we have our CAHN Health Hour session. And CAHN is a program that we have every Saturday. A CAHN Health Hour, is a program we have every Saturday where we have our seasoned consultants, Black consultants and GPs and clinicians offering their time, volunteering their time to equip us, educate us, and empower us so that we can be in better control of our health. It is my pleasure to host you today. My name is Dr. Diana Asante. I'm an NHS GP and the Deputy Primary Care Lead for CAHN. I just want to mention a few things today before we zoom into our topic for today. I know we're in Breast Cancer Month and we had a wonderful session last week, and a special salute to Dr. Ngozi, who's been away for a bit. Lovely to see you. You were looking great. Thanks to all the people who also came out to share their stories to make a difference to the whole thought process about breast cancer and the experiences people have gone through. We also know that we are in Black History Month and there are lots of activities going out, and a salute to all our colleagues who are on those programs as well. Today's discussion is going to be about prostate cancer, and it is a topic that we've had not long ago. But we know that the feedback was great and people still had issues that they wanted to explore, and we are bringing this topic to you again. Now, the CAHN Health Hour is brought to you in conjunction with CAHN, which is a Caribbean and African Health Network, BHI, which is the Black Health Initiative, Croydon BME Forum, Enfield Caribbean Association, Rafa International Development Agency, and the Royal House Redeemed Christian Church of God in Sheffield. And these partners are working very hard behind the scenes to make these programs successful. I also salute all the colleagues who are working behind the scenes to make these programs work week in, week out. So once again, welcome to today's session, which is going to be on prostate cancer. Now, we know that prostate cancer is a very important condition, and we also know that people from African and Caribbean or Black backgrounds, ethnic backgrounds, are at a higher risk of getting prostate cancer, and unfortunately, we do also have a higher mortality rate from this condition. And so it is my honor and my pleasure to introduce to you Dr. Abiye Hector-Goma, who is a seasoned NHS GP, works in Leeds, and he's also on several other programs and fora. He will tell you all about himself in a minute. He has been on this program a few times, and he's a well-known face, a very experienced clinician, and he will be taking us through this topic. You do have the opportunity to ask questions, so do post your questions in the chat box. We're also engaging on YouTube, on Facebook, and Twitter. And so our digital assistants will be engaging you on those platforms. We appreciate your feedback as well for these programs, because it helps us to know how well we're doing, and also to plan further programs. It also helps our sponsors to know whether they're putting their money in the right place. So please, when those feedback forms come around, do fill them in and do comment as we go along. Dr. Abiye Hector-Goma, thank you for taking the time out. I know you're on a holiday, not currently close by, but you have still spared us some time to be on the program. You're most welcome, and over to you. Thank you.
Thank you very much, Diana. It's a delight to be invited back to do a presentation, and more so doing so thousands of miles away. Fingers crossed that technology will be great. So thanks again for the invitation, and Black History Month. It's a good time of the year. Right. So let's start from the very beginning. It's interesting to note that prostate cancer is the most common cancer in men, and there are over 52,000 diagnoses every year. It's about 143 cases per day, and it's said that every 45 minutes, a man dies from prostate cancer. Every 45 minutes, about 12,000 men per year. So that's something that we all should be very concerned with, the men particularly, and the women in our lives. We all need to be quite concerned about it. The statistics also suggest that 1 in 8 men would have a diagnosis of prostate cancer in their lifetime, but it's actually 1 in 4 for us men of African descent. 1 in 4, which is twice what it is for the others. So my name is Abiye Hector-Goma. I'm a GP at Allerton and Westfield Medical Centers in Leeds, and a good friend of Black Health Initiative, which is also based in Leeds. There are some things that we know about and some we don't know about. One is that we, the Black people of African descent, are more likely to have prostate cancer, as I mentioned, and we are less likely to get screened. We don't know why. If we are more likely to have a problem, but we're less likely to get screened to prevent the problem or to identify it early. And also we are more likely to present late for care. And obviously, if we present late for care, we're going to have poorer outcomes. And when people have gone through the process from diagnosis to investigation, from symptoms to diagnosis to investigation to treatment, we also tend to have worse patient experience along that journey of our management. When we come out of it, we have worse patient experience. Even though the management may be fine, but the actual experience of going through management, ours tends to be worse. So we'll have a very, very brief look at the structure and function of the prostate gland, the features of an abnormal function. And we ask the question, is it nature or nurture? And we try to see, how do you reach the man of African descent, the Black man? How do you reach the man? And then what's the journey like when we have symptoms or we decide to get checked? And end up with a call to action for every one of us who, as Christians will say, are under the sound of my voice, as it said, but every one of us here, a kind of a call to action. So the first question here is it genetics? Is it our lifestyle? Or is it environmental factors? So where I am currently, there's a lot of problems. Let me just digress a bit with soot in the air from artisanal refineries. So there's a lot of soot in the air. So if people have problems, is it the environment causing the problems? How is it to access care from diagnosis and management? And more importantly for me, there are things that we can do kind of with the lifestyle choices we make and our health behaviors, our health-seeking behaviors that could make a difference in the issue of prostate. So this is an interesting picture of the structures around the prostate gland. So if we look at this, this is the bladder. This structure here, you can see is labeled as the bladder. You can see the veins, the arteries, and the nerves around. And behind the bladder is the rectum. You can see the rectum here. And then right underneath the bladder is the prostate. And then you have the urethra, the pipe that brings urine from the bladder, which traverses the midpoint of the prostate, and then it goes, and that's the penis, and then the urine comes out. So the obvious thing is that because the urethra passes from the bladder through the prostate, so when the prostate becomes enlarged or there's any disease, it's obvious that symptoms to do with passing urine are one of the obvious things that happen when the prostate gets enlarged. It begins to have an effect on the urethras. And it's just an example. This is the prostate, that's the prostatic urethra. And you can actually see here is an example of where the prostate is diseased. And you can see this is the normal structure of the prostate, but the diseased prostate has a different appearance here. Now, this is another cross-section. So you can see that this is a normal cross-section of the bladder. And you can see where the urethra begins. So you have the prostatic urethra coming down to the penile urethra. Now, this is a normal prostate. And you can see the nice and well-open prostatic urethra where urine can flow freely. Now, when you look at the enlarged prostate on the right side, you can see that the enlarged prostate is now encroaching on the path of the urine, the prostatic urethra. And that's why when we talk about the symptoms, you can see the symptoms here. You can relate to those symptoms because of the narrowing caused by the enlarged prostate encroaching on the prostatic urethra. So if you Google IPSS or International Prostate Symptom Score, this is one message I would first of all leave with all of us, both men and women and the young people here. Just know what the IPSS is. These are 7 questions around the common symptoms that you find with the prostate gland. And if you have these symptoms, or if you just do the IPSS, you know exactly today if you have any symptoms or not. The symptoms are described as mild, moderate, or severe. So the first question is that, do you have any incomplete emptying? You go and wee and you feel like you've not really finished when you finished. Frequency, you find yourself walking back and forth from the loo frequently. Intermittency, where the urine doesn't just flow. Normally, you know, when a man is weeing, the wee just comes, you know, like a blast out. And if it kind of starts and stops, it's intermittent. And again, you can relate to that. When you look at this, it just flows easily, but here it doesn't. And then the next one is urgency. When you need to go, you have to go right away, otherwise you wet yourself. And then weak stream is where if you go to the public toilets, if you look at men who are weeing in the public toilets, some stay 1 mile away from the urinal and they shoot it into the urinal, while others have to go very close to the urinal because the stream is weak. And then straining is where you have to kind of push to get it out. And then some men realize when they push, it doesn't go out. When they relax, it goes out. So straining. And then the 7th one is nocturia, where you find yourself waking up several times in the night to go and pass urine. So these are the 7 key symptoms. And doing the IPSS, the symptoms, you don't need to go to a doctor to do that. You can just download it online and then you can check those questions. So whether it is you, brother, father, any man you know, you can just tell them, just check this IPSS. And that gives us a link there. You can, but online, there are so many of them, you can have a check. And that gives you an idea whether you have symptoms or not. Now, you don't have to wait for symptoms. We'll come to that later. But if you have symptoms, then you have a reason to take action. I already gave some statistics on the incidence of prostate cancer, over 52,000 per year. And in terms of the trend over time is that almost 48% increase over time as at the 1990s. And the peak age is between ages 75 to 79. But having said that, you have people who are 40 to 50, 50 to 60, but the peak age is those who are between 75 and 79 years old. So the next question is it nurture or is it nature? Obviously, we have four main things that affect our health or affect us as human beings. The first one is our genes, what we inherited from our parents. Next one is our lifestyle and behavior. The third one is the quality of healthcare. We have somebody who is, for example, in the UK and has excellent primary health care may have a better, earlier diagnosis than where you're in a part of the world where primary health care is not well organized. And then the environment where we live, work, play, and pray, what kind of environment we live in, because sometimes many churches I know where you have Black majority, there's a lot of awareness of prostate cancer because of the excellent work being done by CAHN, BHI, and other organizations. There's more awareness of it. So these are all the factors that can contribute to prostate cancer. And then here I put the individual's health-seeking behavior. Our family, our culture and upbringing, and what our peers are doing has a massive effect. Again, let me just make a mention. In Leeds, there is a WhatsApp group. There's a group of Nigerian men. We call ourselves kinsmen. We are between ages 45 and 60. And recently, there's been a lot of awareness because of, after I gave the last talk, I shared the slides with them, and we've been kind of challenging ourselves. We're all in that age group. Everybody go and get checked. When people go, they get checked, they come back and then give a thumbs up in the group. And that kind of, it now becomes normal for every one of us to try to get ourselves checked and all that. But if the culture upbringing around you is, there's no real interest in that, then you find yourself not doing much about it. So poor knowledge of prostate cancer, mistrust of the physician or health system, fear of cancer diagnosis. People don't want to go and get checked because they don't want to be told that they have prostate cancer. So fear of the unknown. And then people have kind of fear of the testing procedures. Some of the men in my group, we are not willing to go for a test because they were told you have to have a rectal examination. So they are not keen to have the PS to go for the testing. And I was always asking the question, what is worse, a 1-minute rectal examination, which you find embarrassing, and the other bit of not doing the examination and having a late cancer diagnosis and having all the problems around that? So what do you prefer? So these are the kind of the issues that we need to look at. Now let's talk about the risk factors of prostate cancer. As I mentioned earlier, that the age 75 to 79 age bracket is more likely to have prostate cancer. So the older you are as a man, the risk of having prostate cancer increases. Here we have the genes. Some of us, our fathers had prostate cancer, our uncle had prostate cancer, our elder brother had prostate cancer. It means that we may have genes that are linked to prostate cancer in our bodies, which puts us at a higher risk of having prostate cancer. I know there's a piece of research being done by Prostate Cancer UK, particularly to see what if there are specific genes amongst us as people of African descent, which makes us more likely to have prostate cancer. So the family history, being of African descent, our lifestyle and the environment we live in are all risk factors for prostate cancer. Lifestyle particularly, I think the kind of our diet and being living with obesity and a diet that is rich with red meat may be associated with increased risk of prostate cancer. Those are the risk factors. And I talk about the profile study, which is being done to find out why we are twice as likely as Black men or men of African descent to have prostate cancer. So here I talk about reaching the man, because all said and done, we have to go and get checked whether we have prostate cancer or not. And our health-seeking behavior, all said and done, we can listen to this talk And if after all that has been said, you are 50 or more and you've never had a PSA done and you don't make any effort to go to your GP to request a PSA test, then it means that everything you've had has just fallen on deaf ears. So how do we reach the man? You know, we can reach the man where he lives, where he works, where he plays, and then where he prays. So these are all the areas where people can raise their awareness about prostate cancer, particularly amongst men of African descent. And then again, a man is a son. So if I'm 50 and my mother is still alive and she's here, she's aware of this, she can talk to me to say, son, are we going to check your PSA? Are we going to get yourself checked out? And if you're a sister, you have a brother who is 45 and over, ask him, have you had a PSA done before? Have you gone to see your GP? Or you have a friend, your husband, your father, your co-worker, as a woman, as a man, you've had your PSA test, maybe as a man. If you're working with somebody in the same office and is your age mate is older, ask him, have you had your PSA test? Have you gone to see your GP? So ultimately, through whoever is in this loop of the man should please encourage. So everybody who is listening to me here, encourage the man in your life, whether your brother, your friend, your colleague, your son, or your father, encourage him to go and get checked. Because as I say, stitching time saves 9, and we need to get screened, get a diagnosis early, or get a reassurance early. So we need to reach the man. Now, the obvious test that we all know about is the prostate-specific antigen, the PSA test. It's not a perfect test, but it's the only tool that we have. And here I've just quickly put the pros and cons of a PSA test. Because prostate cancer remains the second commonest cause of cancer deaths in men, and earlier diagnosis and treatment, especially in those who have aggressive forms of the disease, would reduce the burden, disease burden and death. So if somebody has prostate cancer, if he's diagnosed early, he will have a better outcome. And with early diagnosis, you reduce the likelihood of death. And it's also useful for monitoring. So when somebody has had a diagnosis, many years back, once your PSA is high, they go ahead and remove the prostate. But medicine has come a long way. Now, for many people, when the PSA is high, they do tests. They don't hurry to do operation. So some people will talk about that. It's just monitor, see how the levels go over time. So it's useful for monitoring when there has been a diagnosis. So remember, what you don't know may kill you. There's a saying that what you don't know won't kill you. But with prostate cancer, if you don't know that you have it, and if you keep quiet about it, it might lead to your death. But if you go and get checked and you know about it, it might just save your life. Now, there are some negative aspects of it in the sense that for some people, they can have a high reading. Their PSA is high, but it's actually a false high reading. And then some people have a normal PSA and they get reassured, but it's a false reassurance. So you can have some people, their PSA is high, but they don't have prostate cancer. Some have normal PSA, but they actually have prostate cancer. That's kind of, it's not a perfect screening tool. And it can lead to over-treatment, because if your PSA is high, and then you get to see the urologist, and then they do biopsies and things like that. They do scans, do biopsies. So all that can get people quite concerned, only to find at the end of the day that it was a false alarm. And of course, if people get treated, sometimes there are complications of treatment, and you have unnecessary worry when your PSA is high. I was talking to a friend of mine today. I sent him the invitation for today's I sent in a group, and when he saw it, he called me up because he had a recently elevated PSA, and then he had an MRI. He's awaiting a biopsy, and he just came to kind of have second opinion about it. But it was quite good. I didn't have any symptoms. He just went to do a health check, requested a PSA, and then found out that the PSA was elevated. So when you come to us, when you come to your GP, what happens? We take a history, and then we ask those questions about the symptoms and the 7 symptoms, and we do an examination, and then a blood test is done. Now, what we do a rectal examination, it's the medial wall of the rectum. The front of the rectum is the prostate. So we put a glove finger and then we can feel this aspect of the prostate, and we can know from the examination if the prostate is enlarged and if it feels smooth or it feels not quite smooth and all that. So this is what we do. Like I said, it's a 1-minute examination, which it's a stitch in time, which saves 9. Sometimes in some practices, you do the blood test first. When the result comes out, then they decide to do the rectal examination. Sometimes they do the rectal examination and then send the patient for the blood test. So it all depends on what your own GP will do, but definitely the blood test is a must. The rectal examination can be done at the time of the appointment, or it can be done at a separate visit. So if you do your PSA and it's elevated, does it mean that you have prostate cancer? It depends. It depends on these factors, your age. Some people can have a water infection or irritation of the bladder, and that can also contribute to raise PSA. Some people on some medications which can cause their PSA to go up. If a man has had sex or ejaculation in the previous 48 hours, the PSA can be up. Vigorous exercise, again, 2 days before the test, can possibly cause the PSA to be raised. And some people suggest that having catheter passed before the test can also cause it to be raised, as well as a rectal examination may cause the PSA to be raised. So enlarged prostate, inflammation of the prostate or infection of the prostate, stimulation of the prostate are other things that can cause the PSA to be elevated, and not necessarily that because your PSA is elevated that you have prostate cancer. It doesn't follow. So this is one of the reasons why further investigation is now done to now decide what's next. So in the hospital, they don't do a biopsy straight away, which was what was happening before, but research has now shown that if your PSA is elevated, if they rule out other causes like infection and all that, the next thing is to do what is called a multi-parametric MRI scan. And sometimes that scan may show particular parts. Maybe the scan shows that this area of the prostate looks a bit different from the rest of the prostate. And then you are brought back and is done a transrectal ultrasound guided prostate biopsy is done. So they pass the ultrasound probe, and then they'll be able to access that place and do the biopsy. And then the biopsy can now confirm whether or not whatever is seen, whether it is prostate cancer or it's just benign enlargement of the prostate. And a CT scan or bone scans may also be done. I will leave this bit. These are the things that the urologists will discuss with you if the tests are suggestive of cancer. And then the staging that is done, this is, treatment is individualized. They look at quite a lot of factors, and this software works, the urologist uses software, input all this information, and then with that, management plan, which is individualized to the person, will now be put in place by the urologist. This is just what you can see. In this one, that's the prostate. You can see here, it's called T1 prostate cancer, is within the capsule of the prostate, is far from the edge. And then 2 is it can be felt or seen, but it is contained within the prostate, has not gone beyond the prostate. And then T3 is when it has advanced locally, and then T4 when it has gone beyond the locality to other organs. So it says 85% of newly diagnosed prostate cancer is localized disease. So this is just the normal prostate. You can see this is a prostate cancer. It is localized disease. And they say 85% of newly diagnosed is localized. So like I mentioned, it's individualized treatment from diagnosis. So active surveillance or watchful waiting. So what really happens is that the urologist decides with the patient and do either serial every 6 months, they do a PSA level. If it doubles, then they go ahead and decide what specific treatment will be required, whether surgery, radiotherapy, or hormone therapy, depending on the individual patient. So the point is that no longer people are put straight to go and do surgery. The urologist discusses with the patients, and then they have a management plan for the patient. So active surveillance. So these are the kind of the various modalities for treatment in hospital, from surveillance, radical prostatectomy, radiotherapy, high frequency ultrasound, or brachytherapy, where they put radiation seeds in the prostate. So call to action, what are the things that we need to do? One is somewhere along the line, there may be research may show that some people have genes that can kind of interact with the environment and cause prostate cancer. So maybe gene therapy will be something of the future. From a lifestyle point of view, it's the same lifestyle advice: cut back on fat, salt, sugar, more of fruits and vegetables, more of exercise. If every little helps, try to lose weight. If you're overweight, sleep better, manage money better, and try and be happy. Health-seeking behavior is important. Any man here who is 45 and above, as a Black man, if you've never had a PSA test, please go and request a PSA test. You may have issues with your GP. We'll talk about that, but please make sure that if you're 45 and over, as a Black man, you request a PSA test if you've not done one before. Read about the pros and cons and decide. And then book an appointment, and then the follow-up, whatever medications and whatever is being done, try to do the right thing for your health. And for us as health service providers, as the attitudes and practices of health workers is something that sometimes has an effect on patients. And inverse care law is still in operation, where people who are well, the poor are less likely to have access to healthcare, and that's still a problem. So when you have programs like this by CAHN and giving you all the information you need, then you need to go and have yourselves checked. So just to say here again that if you're under 45, you don't need to have a check, just know the symptoms. But anybody who is 45 and over, don't wait for symptoms. If you're 45 and over as a Black man, request your PSA. If it's normal, that's the baseline. If tomorrow it goes up, you have a baseline to compare with, and that would be my advice. But definitely if you're 50 and over, I would say you must have a test done. If you're 50 and over and you have symptoms, please go and see your GP on Monday. Just don't wait for another week or another month. This link is very important. Time is gone now, but just to say that this link here on Prostate Cancer UK website tells us as men of African descent what to do if we're under 45, if we're 45 to 50, if you're 50 and above. You have a right, if you're 50, to demand a PSA. 45 and up, between 45 and 50, it is not your right. But if you read and you weighed it, you can request a PSA. But 50 and above, it is your right in the UK to get a PSA. 45 to 50, you should request it. And if your GP says no, this link tells you what you can do to make sure that your GP gives you what you require for a PSA test once you're 45 and above. So remember, there's no point being embarrassed. You are aware of prostate cancer. You know it affects us twice as much as the rest of the population. Please, you have to do something about it. Don't wait for symptoms. Request a PSA and look after yourself. And this QR code tells us how we can check our risk of a prostate cancer in 30 seconds. But as far as I'm concerned, if you're 45 and above as a Black man, you've not had a PSA test, request it from your GP. That is my message for all of us for today. Thank you for listening, and we'll take some conversation from here on.
Thank you so much, Dr. Abiye Hector-Goma. You've delivered a great session once again. A few weeks ago, wasn't it? We had this conversation about prostate cancer, and we're having it again. It just goes to show the importance of this topic, and also how it really impacts each and every one of us in one way or another. So as you've said, let's all reach out to the men in our lives, whether it's a son, a brother, an uncle, a pastor, a friend, a neighbor, a work colleague. Let's spread the message. There are not enough men getting themselves checked. There are not enough men who are presenting when they have symptoms, and we're leaving things late. And you hit the nail right on the head, and you said, men of Black ethnic minority are at a higher risk, and yet they're the ones who are less, less sort of proactive, if you like, in going forward for a various number of reasons. So please don't be embarrassed, and we've learned something that gives us that impetus to go and seek some help and ask some questions to your doctor if you're not sure. On the same thread of prostate cancer, I just want to put out there that there is a Greater Manchester Prostate Cancer Alliance program coming off on Wednesday, the 12th of October. So that is an interactive session on prostate cancer as well. And there will be the opportunity for feedback to be taken and quite a lot of interaction as well. So once again, thank you so much, Dr. Abiye Hector-Goma. So we'll zoom straight into questions. I can see someone's put their hand up. Fortunately, I've got you on my screen and I can see your hand up, but for those who I might not see directly, please, if you want to put your hand up, you can use the icon. But I think DK Stars, is that
That's
right?
correct. Yes, it is correct. Yes.
Kindly ask your question.
Yes. By the way, many thanks for a well-delivered session to the doctor. What I want to find out, or what will be useful to share, is the personal individual responsibility that one should take in terms of exercise before operation and post-operation. So I hear people talk about pelvic floor exercise, etc., etc. Any other advice that one should take upon themselves to undertake whilst the professionals are doing what they have to do?
Right. I mean, from exercise point of view, the key things are there are three main exercise things as the exercise for flexibility, for strengthening, and then aerobics. So those are the three kinds of exercise. And as far as you are able to do anything, I mean, I always say anything that will make you sweat, to make you breathe faster, and to make your heart beat faster is exercise. So whatever that can help you achieve those three things, and then having both aerobics, flexibility, as well as strengthening exercises, I mean, that's fine. But are you talking about I'm not aware of specific exercises pre and post prostate cancer. I'm not aware of anything that you need to do specifically around that.
Okay.
Exercise to be healthy, and then to encourage weight loss and all of that. Yes. But
yes.
We do for exercises.
Okay. Thank you for that. Yes. I mean, I'm aware of the general exercises, whole body exercises. I was thinking of exercises specific to the area and the muscles around there to help before operation, after operation, before treatment, after treatment. I did hear about pelvic floor exercise. I wasn't sure.
Yeah, I mean, pelvic floor exercises are fine. And pelvic floor exercises are simply if you're weeing and you want to, if you stop the urine abruptly, the muscles that you use to stop the urine abruptly, that's a pelvic floor exercises. And you can just sit down and you can be watching, driving. You can just be doing, by just using the same muscles to stop the wee. Those are the pelvic floor exercises. I mean, pelvic floor muscles that you are strengthening.
Okay, many thanks. Many thanks.
Thank you for that question, DK Stas, and thank you, Dr. Goma, for answering that. Yeah, so there's a question in the chat box about at what point will a doctor prescribe Bicolutamide for someone with BPH, especially when it's not been confirmed as cancerous. So presumably it appears that someone might be on Bicolutamide when they haven't had a firm cancer diagnosis. At what point is that likely to be the case? Abiye would like to know.
Okay, I mean, I'm not a urologist, but one thing I know is that it's used for metastatic prostate cancer treatment based on anti-androgen medication. So I'm not aware of using it, in a pre-cancerous situation. You use other medication to shrink the prostate, but if somebody does not have prostate cancer, unless a urologist has his or her reason for prescribing it, but in primary care, we wouldn't prescribe Bicolutamide for somebody who's not been diagnosed with metastatic prostate cancer. Yeah. So I'm not aware of that use.
Thank you. And I don't know, Abiye, whether you might have a bit more information you want to add to that question, or if you're in the position to unmute yourself. But I completely agree with Dr. Goma. It's not something that we would normally use for a benign prostatic hypertrophy tends to be that people who have got cancer are the ones that the urologist prescribe for. So if you do have more, a follow-up to that, please give that information and we can deliberate a bit more. Dr. Goma, what are the signs that people should look out for prostate cancer? So Rachel would want you to sort of summarize, are there specific signs? Do we get signs at all? Do we not? And when we do, what do we look out for? Okay,
I remember I mentioned the IPSS, the seven symptoms. Because of where the prostate is, those are the first signs that we look out for, and anything more than that is actually a lot more kind of advanced. So the first thing I would say is don't wait for signs. If you're in the age bracket, like I mentioned, then have yourself checked. But the main symptoms to look out for are the incomplete emptying of the bladder, having frequency, having intermittency of urine, having urgency, a weak stream, straining to pass urine, or finding yourself waking up several times in the night to wee. Obviously, things like blood in the urine or back pain, those are bad signs. You know, if you have such things, you know, back pain, particularly if you have symptoms and then you have back pain, that's something like a red flag, it's an alarm sign. So blood in the urine as well as back pain are very worrying symptoms, but the earlier ones are the ones that I've just mentioned. Thank you for that. And that message of don't wait for signs is very critical to all of us, because a lot of time people are waiting to see what symptoms they will get first or what signs. And specifically with prostate cancer, as you said, Dr. Goma, most people don't have any symptoms until it's too late. So by the time someone is presenting with a bone pain or the weight loss or change of appetite or, you know, all those urination symptoms, it might actually be too late. So please, let's hear the advice is given about if you're a man of Black ethnicity and you're 45 or over, if you've never had a PSA, you should be getting a PSA done. So that's very important for all of us. In terms of prostate cancer, is it possible for it to recur? So is it possible that if someone has had prostate cancer, they've been treated, can they have a recurrence at all? Yeah, definitely. It is possible. Like anything else, you could have a few cells that are left, you know, and that's the whole idea of having PSA. Even after treatment, you find that you have PSA being done either every 6 months, every year. And as long as, so sometimes somebody, let's say somebody's PSA at diagnosis was 20, and after treatment it comes to maybe 0.01. And then for the next 5 years, it's 0.01. And then 1 year it becomes 0.1 or even 1. Now, the upper limit of normal is, say, I think it's 2.9 for some age groups. So even though 1 is quite within the normal limits, but because this person has had 0.01 for many years and suddenly it becomes 1, it's an alarm bell for the urologist, because it means that the activity has resumed. So definitely it is possible to have a recurrence. And that's why it's important to follow the advice of the urologist. And currently what we have is that maybe every 6 months, every year, you get a reminder to go to your GP and have the blood test done. You have the blood test done, they can see the results and then send you a message or call you. So everything is fine, do your test again in 6 months or in a year's time. Unless you have symptoms, then come back sooner. So definitely recurrence can happen. Thank you for clarifying that as well. Yeah. So please, if you are under PSA surveillance, do ensure that you carry on with it, because some people might feel that, oh, my PSA has been down for so many years, I don't need to keep following this up. But as Doc has said, it can happen again, so please. Just on that topic of bone pain, it brings to mind a patient we had just a few weeks ago who was presenting with bone pain. He was a 65-year-old gentleman, and he had a history of pre-existing back problems for so many years, and recently his back was getting worse, and he presented with pain in the back. So sorry, back pain was his, not bone pain. He was presenting with back pain, but this is someone who had pre-existing back pain for a long time. So he'd seen the physios, he was on painkillers, and now he was saying, my back pain is getting worse, my back pain is getting worse. And he was sent for a bit more physio, and it still wasn't getting better. And he had a PSA test, and it turned out, unfortunately, that he had cancer
prostate cancer, which had spread. So it's just regarding the back pain, because I know that a lot of people can be quite dismissive of back pain. And you've said, Dr. Goma, that when we have bone pain, so not everyone knows what bone pain is, but those who know it, they know it because it's an unusual pain. But even as you said, if you're over 60 and you're getting back pain, which is not explained, don't feel fobbed off, don't be dismissed, don't say that, oh, I've always had this back pain. If it's different, please see your doctor. I don't know what you've got to say in addition to that.
Yeah, I mean, like you said, definitely maybe 95% of back pain is musculoskeletal, but there's always that 5%. So more so if you're a man of African descent who is over 50 or 60s or 70s, and the back pain is persistent, then if you haven't had a PSA test done recently, tell your doctor, can you check for cancer, for example, then that maybe make the doctor check for PSA, do a myeloma screen, and then I'll also do a PSA. And if they've done a myeloma screen and they've done a PSA, it comes back normal, and that's reassuring. It doesn't mean that in the next year or two, it's not getting better, again, it can represent, because sometimes it takes a much longer time for it to manifest, but at least definitely requesting further investigation, particularly PSA as well as myeloma screening. I mean, you can ask your doctor if you're in that kind of age bracket and the pain is not going away, that can you read about it and then request it, you know. But I would expect that your GP would request such tests. Maybe they will have done it and it's come back normal, but ask and then you'd know if it's been done or not. If it's not been done, then request it.
Thank you for that too. So Doc, we've got someone who's tuning in from States, from the USA, and he's saying that, greetings, Doc, and obviously thanking you for the lovely presentation. He said, in our part of the world where doctors push for aggressive treatment because of insurance payments, how does one handle or avert aggressive treatment resulting from false readings? So I guess this is a situation which would be more specific to being in America. Any thoughts on that?
It's a bit difficult, but I think we're in the information age now, and it would be good to see what is practiced in different parts of the world. So, for example, practice has changed a few years ago, and that's based on evidence. So you can get information to say these are the British guidelines of urology, and this is what it says. You know, so why is your advice different from that? And if maybe seek second opinion, and I mean, if you can travel to the UK and have second opinion, or even these days you can do online, video consultation. Seek an excellent urologist, send him your information, send him your results, send her your results, and have a conversation. Just get a second opinion, and they can say, well, this is what we do here. You know, these are the options that you have. But like I mentioned earlier on, most times now the management is personalized. It's an individual management plan. So you get your information, seek second opinion, maybe from a urologist in the UK or in Europe, and hear what they say. If they all say the same thing to what your urologist has said in America, then you can go ahead with it. But if different people have said different things, then you can say, rather do serial PSA or whatever it is. But I would say, I quite agree with you that sometimes people hurry to do things because they get paid for it, and just serial PSA is not going to give them enough money. I think it's good to get second opinion.
Absolutely, yes. If in doubt, seek a second opinion. And we are very fortunate in the UK, aren't we? Because we've got the national health system where things are streamlined, and you know, we have these things which sometimes we almost take for granted because we get them free on the NHS. But no, clearly there are people not as fortunate who have to pay for every single test and every single service, and even people who, even with their money, don't have access to these services. So,
gentlemen,
right. Yeah, DK Stas, you've got another question? Sorry, you are muted. You'd like to unmute yourself, please.
Okay. You mentioned two things, suspicion of health professionals, and you also mentioned the active monitoring and the watch and wait approach. My question is there anything complementary? I know it's not your area of specialism, but anything in complementary medicine that one can be taking during the watch and wait or the active monitoring that may influence it from your experience or from any experience of your associates?
Well, what I'll say is that, like you said, it's not my area of expertise, but our fathers, our ancestors used herbs and various things, and they lived, and because it's not gone through the rigorous, as I know, of control tests and double blind, all those kind of, doesn't mean that it won't work. What I always say is that anything that is herbal or natural, it may do good, as long as it's not something that is harmful. Because, for example, there are some products that are full of salt. So even if it's something that may be helpful, if it is loaded with salt, that can cause its own problems. But if it's a herb or a natural thing that will do no harm, I always say that you never know until you try. But I don't know of any particular thing that can make a difference and shrink or cure prostate cancer. But I always say anything that is herbal, as long as you know what is in the herbs, is not something that is high in anything that is negative. I mean, some people say if you drink a lot of, let's say, bitter leaf, it will help blood sugars. And I always say to them, I have no idea if it works, but bitter leaf is what we used to cook at home. So fine, use it. If the blood sugar levels come down, then so be it. I would say I don't know about it, but I won't discountenance it because I don't know about it.
Okay. All right. Thank you. Thank you.
Thank you. Thank you very much. Dr. Goma, please, Neville would like to know, is there a clinical reason why men in the 50-year-old bracket aren't routinely invited to a PSA test as women who reach a certain age for screening? So is it the case? And why is that?
Yeah, like I mentioned briefly during my presentation, a good screening tool, if it says the result is positive, then it is positive. If it says it is negative, it is negative. But PSA has quite a bit of false positive and a bit of false negative. Like I mentioned, the possible causes like just having ejaculation 2 days earlier, having vigorous exercise, having water infection, having catheterization, that kind of make you have a falsely elevated result. So because of that, the PSA as it is currently is not a very sensitive test, and a good screening test has to be very sensitive. And that's the main drawback for the PSA test. And that's why it's not universally available. And it also causes a bit of confusion, because if you do two or three doctors around the PSA, you get different advice from different doctors. And that's why I feel that it is just better to get it done, by yourself. And even if your GP is not willing to give it to you, I don't think it costs more than £10. I'm not sure, to do it privately. But I'm sure you can either get your GP to do it for you or just pay and get it done privately. But it's not a very sensitive test. But for now, it's still the only test that is available. And that's why routinely it's not done as an NHS screening tool for every male who is 50 and above.
Thank you. Neville, I hope that answers your question. Thanks,
and just
Dr.
to add to that, when you now have a false positive, you now have to go through so many tests, MRI, biopsy, and all of that, which is also very expensive for the NHS. And at the end, it could have been a false positive. And that's why there are those limitations about its use, around for everybody.
Okay, thank you. Thank you. Now, when people have had prostate cancer surgery or treatment, is there any possibility, Dr. Abiye, that they might lose their ejaculatory function or their sexual function? Because I know that a lot of men are quite worried about that, about not being able to perform after treatment.
Yes, I mean, sadly, so one of my mentors, when he had prostate cancer, and he was told about the likelihood of impotence, and he just said, yank it out. I've used it long enough, I have other things to live for, which is fine because he was an academic and he had things to do. But that is actually a risk that impotence, that's one of the reasons why people are always very reluctant to get into it, because for many men, particularly men of African descent, The sexual activity is quite an important part. And I guess also one of the reasons why the whole idea of surveillance and watchful waiting comes in, because a lot of the prostate cancer is not aggressive and people can live to old age and die. And I think it was when they did a lot of postmortems, they found people who were not known to have prostate cancer at postmortem were found to have prostate cancer in their 80s and all that. So, and that's why the whole concept of rushing to do surgeries has now been overtaken by knowledge that you do surveillance for some people, except it's very obvious that it's aggressive. But just doing the serial PSAs, if it's just remaining the same, 2.9, 2.3.0, you don't bother to dash in. But if it begins to double, then, for this person, it's an aggressive one. So it's better to get it treated. So when you look at it, it's about the risk versus the benefits. If, for example, you're a man of African descent, you are 55, and you have an aggressive prostate cancer, you have to wait. Should I lose my manhood, or should I keep it and die in a year's time? So you can now, you weigh and you make an individual decision. You look at your family and all of that, and you make a decision. But definitely that is and unfortunately at this stage of medical practice is a side effect. Some people say it will come back later, but for some people it doesn't come back.
Yeah. And thanks for that. And also that's why we also need to support each other through these processes, through these journeys, so that I think we mentioned this the last time about these topics are not just for the man, but even for us, the women in the men's lives, because if you're the spouse of that man who's got to go through this treatment and he's worrying that he's not going to be able to satisfy his wife, then I think that supportive discussion between the two of you, knowing what you're both getting yourself into, what lies the aftermath, can make the journey a bit easier for both parties. Are there any things that people can do if they find themselves in that situation? Sorry, I put you in a tight spot on that one. But if someone ended up, they've had treatment, they're now impotent, are there options for them, or really is that the end of the road in terms of?
No, well, it's not. I mean, there are options. There are pharmacological options to use. So sildenafil or Viagra is an option to try. And then again, the urologist can look at other options like that, the physical equipment that can be used to cause erections, again, kind of the physical devices. So for the pharmacological devices, and then the physical devices that can be used to have inflation around the penis. But the key thing is that somebody has put in that, which is quite right, is that treatment is quite individualized. So when they put all those factors of your PSA, your the grading and all of that, they now look at the various treatment options. They say, if we did this, this could happen. If we did this, this could happen. So at the end of the day, you have all the information and then you make an informed choice. And the good thing is that, when all the information is put at the disposal of the patient, you make the decision. And we as clinicians, if I would say maybe in your position, I would have chosen option C, but you've chosen option A, and that's fine. We are guests in the lives of our patients. So once you've made your decision, this is what I want, then the urologist will go ahead and do what you've chosen as against what he or she may think is the best. But once you've made an informed choice, they'll go with it.
Thank you so much. So please, let's not be put off. Let's not think that that's the end of the road. If you've got to choose between your life and your sexual function, make the right choice, and which is best for you and best for your family. And Vanessa, thanks for that very important comment about the fact that patients have to understand the disease and how it affects them individually. And patients should attend these consultations with the questions that they have, which will help support them to make the right choices, the right decisions. So it is important that you're engaged in the process. If anything's not clear, you clarify before you go ahead. I know that we are all pressured these days, and because of time constraints, sometimes the consultations are a bit rushed, and but if you're not sure, if you're not clear, have another consultation with your consultant. Be absolutely clear on what you're getting yourself into before you go ahead with it. And they're very supportive. They're nurse specialists. There are other members of the team who can take their time and explain things to you. And groups like Dr. Hector was talking about are also useful to share experiences with other men who've been through these sorts of procedures. Thank you. Ayo, George, you've got your hand up. George Ayo, you've got your hand up. Would you like to unmute, please, and ask your question?
Thank you so much. Thank you so much for this presentation. It's been very, 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 very educating. Please, I just want to ask the doctor, like, how many times you reckon will be normal for one to be going to toilet in the night?
I would say that again, it's individual dependent, but I would say, I mean, 0 to 1 should be normal, 0 to 1. I mean, 2 and above would probably be something that you should check. But again, it won't just be one. Like we said, the IPSS has 7 symptoms, but for nocturia, I would say 0 to 1 would be normal.
Thank you. Ayo, does that help, George?
Yeah, that's it. Thank you so much.
All
You're
right.
welcome. Yeah, and also just to add to that, there are other things. I mean, obviously, there are lots of things, isn't it, that can make people wake up at night. So just basic things that we might take for granted, like Dr. Hector-Goma was saying, our lifestyle. So if you're drinking late into the night, if you're having caffeine, if you're drinking alcohol, you know, if you're on a tablet that makes you weak, all of those things can make you be up and about throughout the night. So once we've checked all those things, and if you're doing all the right things, then I agree with him. If you're doing it more than twice a night when you weren't before, then you probably should have a chat to somebody. Yeah, thank you for that. That's a really useful question. Abundance, you've got your hand up as well. Can you unmute yourself, please, and ask your question?
The question I want to ask is, hello everyone. Sorry for not introducing. The question I want to ask is, how does this prostate cancer start? Like the early stage, like I have a friend, he has a bump in his testicles, and just early stage, and he started developing. It was a little bit painful, but not that painful. So he googled about it. It was like it might be a harmless something, it might be serious something. So that's the question I want to ask. So what do you?
Okay, well, if go on.
So what was the overview explanation of what could be going on?
Okay, if you were there when I showed the slide, let me see if I can bring it back. Just the anatomy, which shows where the prostate is. If you can see the current slide. Sorry. So it's just the slide that shows the prostate. Can you see my slide?
Yes, we can see the slide.
Okay,
yes,
so you can see here that this is the bladder, and then you have the prostate gland on the side. So urine passes down the prostate. Here, the prostate is enlarged, so where the urine passes is narrow. So the symptoms that commonly we see have to do with whether the urine is passing freely or is not passing freely. So straining, urgency, intermittency, weak stream, waking up in the night to wee are the commoner early symptoms that you see. By the time there's blood in the urine or somebody's having back pain or bone pain, those are bad signs. So the first thing is that there may be no symptom at all. You know, the gentleman I was speaking to today just did a health check and did his PSA, and it was found his PSA was elevated. So for some people, there are no symptoms, and that is the best time. But if you have symptoms, then the earlier you get the PSA done, the better. Don't really wait for symptoms, but these are the common symptoms that you find because they have to do with the anatomy of where the prostate is with respect of urine passing from the bladder to the penis.
Does that help you,
Okay.
Abundance?
Yeah, that helps. So like a bump in the testicles doesn't have to do with the prostate
So
cancer.
that needs to be examined as a matter of urgency, because a bump in the testicle may be a testicular lump, which might be benign or something more sinister. So he needs to go and see his doctors and his GP and have it checked. But it's unlikely to have anything to do with the prostate, but that's also a problem. Testicular cancer, varicocele, there are kind of problems, hernia, problems that are, but he just needs to have it checked by his GP.
Okay, thank you so much.
All right.
Thank you. Thanks for your question. Yeah, so please tell your friend to get it checked if he's got a lump in the testis. Don't leave it any longer. Thank you so much, Dr. Hector-Goma. So a lot of comments about what an amazing presentation it's been. Emily Fosso said the presentation was amazing. Deji said, very good presentation. Thank you, Dr. Hector. Aleshin Loye said, brilliant presentation. Talk has been beneficial. And same with Emmanuel, very educative program. Thank you, Dr. Abiye and Diana. And lots of feedback, John, as well. So hopefully we're all benefiting from this, which is the whole point of us having these discussions, and we're grateful that it's of some use to somebody. Andrew would like to know, has there been any research on the higher prevalence of prostate cancer in the African and Caribbean males, in particular looking at factors of genetics, lifestyles, environment, access to care? Seeing if one is more of a factor than others, or whether they all sort of play a part. So basically, are we aware of any research that is going on in this area?
Yes, there is a profile study, I think it's going on in the UK currently. If you go to Prostate Cancer UK website, and I think there's even a section where you can get, if you want to participate in the study. I don't know if they're still taking new people in the study, but definitely profile study is ongoing, which is just looking at whether genes, there are specific genes that are commoner amongst our people, which are responsible for prostate cancer, particularly in those people where you have father, son, brother, and all of that have had prostate cancer. So that's an ongoing study. And of course, there's the issue of gene and the environment, the link between the genes, because some people may have the genes and they are fine, others have the genes and have, you know, lifestyles which are not very great. So that interaction between the gene and environment is there, but it's an ongoing study, the profile study.
Thank you. And if people do get to know about any of these studies and volunteers are needed, please let's also come forward, because if we don't volunteer, we don't get to know what happens in our ethnic sort of subgroups. But thanks for all the wonderful comments coming in. The feedback forms will be sent out, or if they haven't been sent already, please do fill these in, because it helps us to know where we need to improve. I just want to chip something in very briefly. A couple of weeks ago, we had a session on blood pressure, and we said we were going to give out some blood pressure machines. So the winners were announced last week by Dr. Ngozi, but just in case you weren't on last week, in case you were a winner and you weren't on last week, the names of the 5 people who won are Iyabo Fashion, Rosie A, Betty Wilson, Julian Luwaye, and V. Ebanks. So those are the 5 people who won, and in due course, CAHN will be contacting you to send your blood pressure machines to you. And also on Tuesday, we have our Healthy Heart session, which is in relation to nutrition and sexual health. So we've been talking about how can we make ourselves stronger and better, so that even if we do have some of these conditions, our body can tolerate it better. Dr. Goma has also talked about lifestyle. Please join the Healthy Heart session. And on Wednesday, I just want to also emphasize that prostate cancer interactive session as well, which we have. So Dr. Goma, 2 last questions for you, and then we will bring the Q&A session to a close. So I've got 2 more questions in there. Thank you to everyone who has contributed or sent in a question or a comment, who's tuned in today. It all enriches these sessions and makes it interesting. So the 2 questions, one from Emily. She says, how do we know a form of cancer, prostate cancer, is an aggressive form? So how would we know?
Okay,
and then,
okay, go on.
Well, you carry on, because I think the second one is probably more of a comment from Vanessa. She's saying early intervention for any health issues is key to successful outcomes, and also to allay fears and anxiety. So totally agree with that, Vanessa. But how do we know if a prostate cancer is aggressive?
All right. I mean, the commonest way to know is when you do the serial PSA. So if you do a PSA test and you do another one in 6 months' time and it has doubled, that is more likely to be an aggressive one. While if the PSA level remains about the same, as increased very slightly, then it's less likely to be that. So that's a common test that is used. Or if you have somebody who had a PSA and then had no symptoms and suddenly has, significant symptoms, that may still be a benign one, but the doubling of the prostate within a short time is one of the first things that will now make the urologist, kind of go ahead to do an intervention. And then of course, if they do a test and say you did an MRI and you saw some maybe localized prostate, and then maybe you did this PSA doubles very quickly, you did another MRI, which now showed that from where it was is now maybe gone from T1 to T2 or T2 to T1 to T3, that suggests that this is an aggressive form of prostate cancer.
Thank you for clarifying.
Okay. As a question on nerve sparing, let's see, on nerve sparing, which is, I guess, is the issue of trying to avoid impotence. So as a question on that, on nerve sparing surgery.
Nerve sparing surgery, right?
Yes,
okay.
Yes. So yeah, for people who have localized, remember what the diagram that showed localized prostate cancer, where you just have the lesion which has not even reached the capsule of the prostate. For such lesions, you now have the robotic laparoscopic prostatectomy, which is actually, you have the urologist controlling the robots from, and with that, it's kind of even more precise. And those are techniques that are used for localized prostate cancer, and they are more likely to spare the very important nerves. And that is for localized prostatic. If it is more advanced, then of course you need something more aggressive, which in the process you lose the nerves. But if it's localized prostatic cancer, then robotic surgery can carefully avoid the nerves, even though the person I mentioned had robotic surgery and still was important afterwards. But at least that gives you the option of nerve sparing surgery.
Thank you for that as well, which is a useful alternative if it's suitable for that patient. And at this point, I just want to say a huge thank you to you, Dr. Abiye Hector-Goma. I can't stop saying that you're actually on holiday in Nigeria and you tuned in, defied all the odds of technological interference and everything else, and just spared us your precious time to volunteer your time today to tell us about this. So we really, really appreciate you. God bless you so much. And I hope whatever you're doing there comes to fruition and successfully you come back and join us in the UK. And thank you to everyone who's made today's session as interactive as possible with your questions, with your comments, with your contributions, with your feedback. We really value these. It gives us a reason to get up every morning and come and sit here. I tell you, sometimes it's a challenge and I think, but it's so great when we have these opportunities just to equip each other and just share with each other and uplift each other and be there for each other. It makes a massive difference. So please do tune in, week out. So someone was asking about the Tuesday sessions and saying, is it the same Zoom ID? It is, isn't it? Yes, it's the same Zoom ID. Lande, please correct me if I'm wrong. It's the same Zoom ID. And if you've got Facebook, please check out CAHN or CAHN, and you get all these programs that we do. You will be flagged up so that you're aware of what's going on. You're in the loop, and you can always join in for the weekly sessions that we do. But once again, thank you so much, Dr. Hector-Goma. 3 things I want you to tell us, 3 messages to take home, and then I'll be handing over to Lande to do the closing. 3 messages to take home.
1, look after yourself. Your lifestyle is in your hands. It's not to do with the health service. Look after yourself. And then 2, get checked. Do a PSA. If you're a man who is 45, request a PSA, get checked. And then 3, you never know until you get checked, and your doctors will work with you and will work with you to decide what's the best option if you find that your test is positive.
Thank you so much. Over to you, Lande, for the closing. And it's been my pleasure hosting you today. My name is Dr. Diana Asante. Thank you.
Cheers.
Thank you, Dr. Diana. Thank you for your excellent moderation of today's program, as always. And Dr. Hector-Goma, we appreciate you sharing your time and your expertise with us again. Thank you for always answering when we call upon you. And do enjoy your time on holiday in Nigeria. And to everyone who has joined us today, we appreciate you. Thank you for spending your Saturday morning with us, as you usually do. We know that so many of you tune in every Saturday, and you've told your family, your friends, and your members of your community as well. So we appreciate that. I would like to acknowledge the CAHN partners, without whom these sessions would not be possible. And I would encourage you to look for the partners, the CAHN partners in your region, and do make contact with them, please. So we've got CAHN, the Caribbean and African Health Network. We've also got the Black Health Initiative. We've got Croydon BME Forum, the Enfield Caribbean Association, the Royal Assembly Redeemed Christian Church of God, and RAFA International Development Agency. So as Dr. Diana mentioned earlier, we'll be having a special midweek CAHN Health Hour, focusing on prostate cancer, again, by special request. We do find that this topic is really very topical, and members of our community are very interested in hearing about this. So please join us for this midweek one. It's going to be more interactive than usual, and it will feature a consultant urological surgeon from Greater Manchester. So please join us this Wednesday, coming Wednesday, 12th October, from 7:30 p.m. to 8:45 p.m. We will be back with our usual Saturday CAHN Health Hour next Saturday, 15th of October. It will be on cervical cancer, and the focus will be on prevention. So please join us. To register, you can email events@cahn.org.uk, and also look out for more information from the platforms and the CAHN partners that you receive information from. There will also be our usual Healthy Heart session on Tuesday, 4th of October. This time it will be on nutrition and sexual health. To register for this, please email events@cahn.org.uk. And this is one that's very special to my heart. CAHN will be celebrating its 5th anniversary gala and awards night on the 22nd of October. This is something you don't want to miss. This is going to be the soiree of the year. So please, please join us. Tickets are selling out fast, so please book yours today. Head over to portal.cahn.org.uk/gala. And to tell you a little bit more about the gala, we will be sharing a video with you. So once again, thank you all for joining us today. And please do have a lovely weekend, and see you on Wednesday and then on Saturday next week. Take care, everyone. Bye-bye.
Hello there, my name is Gillian Joseph, and I want to tell you about an amazing night that I'm hosting for the Caribbean and African Health Network. They have a vision to end health inequalities for Caribbean and African people and end wider health disparities. To that end, they're holding this fundraising awards gala in Manchester at the Hilton on the 22nd of October. You can wine and dine, dance and be entertained. I'll be there. Hope to see you.
Welcome to our Caribbean and African Targeted Health Improvement Program, CAHN Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members, such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CAHN is funded by the National Lottery Community Fund.